Hello, my name is Alicia Algeciras-Schimnich, and I'm a professor of laboratory medicine and pathology at Mayo Clinic in Rochester, Minnesota. Today, I'm going to be discussing the topic of Alzheimer's disease blood biomarkers. During this talk, I will discuss the increasing importance of blood biomarkers in the early diagnosis of Alzheimer's disease, recognize differences in the intended use of the different Alzheimer's disease blood biomarkers, and discuss some of the future clinical applications of these biomarkers. Blood biomarkers of Alzheimer's disease are rapidly transitioning from a research tool to a clinical test. For example, the revised criteria for diagnosis and staging of Alzheimer's disease, published by the Alzheimer's Association Working Group, support the use of blood biomarkers in the diagnosis of Alzheimer's disease. These are blood biomarkers that have a minimum accuracy of 90% for detection of amyloid pathology in the intended use population, which in this case are those individuals with symptoms of cognitive decline. Specifically, they call out plasma p-tau217 assays, are those tests that are able to achieve that level of diagnostic accuracy. In addition, as you can see in this table, other blood biomarkers are being proposed as part of the staging and the prognosis of Alzheimer's disease, as well as for the identification of AD co-pathologies. For example, we have biomarkers for neurodegeneration or neuronal injuries, such as NFL, or biomarkers of astrocyte activation or inflammation, such as GFAP, that can be used in the workup of these patients. We also have biomarkers for alpha-synuclein. However, these biomarkers are only available today in CSF. Plasma p-tau217 has been shown to outperform our other AD blood biomarkers in predicting Alzheimer's disease pathology. For example, in this figure that shows a comparison of a number of commercially available p-tau217 assays, including both mass spectrometry assays and immunoassays, a comparison of p-tau217 with other biomarkers such as plasma p-tau181 and the plasma beta 4240 have shown that the p-tau217 has the highest diagnostic accuracy as determined by the ROC-AUC evaluation for prediction of amyloid pathology. In addition, p-tau217 has been shown to have a strong agreement with both CSF amyloid biomarkers and PET imaging, and been shown to detect both amyloid and tau pathology in individuals with symptoms of cognitive decline. More importantly, we need to recognize that when we look at the comparisons between p-tau217 and A-beta 42, that p-tau217 has a better diagnostic accuracy than A-beta 4240 in identifying AD pathology as well as in the prediction of disease progression. When we look at the clinical use of AD blood biomarkers in the current state, these biomarkers are only recommended to be used in individuals with symptoms of objective cognitive decline. And these biomarkers can be used in order to improve the accuracy of a dementia diagnosis, to determine the eligibility to anti-amyloid therapies. However, it's very important to know and understand that these biomarkers are not recommended today for the use in cognitively unimpaired individuals, meaning those individuals that do not have any symptoms of cognitive decline. When we look at the most current Alzheimer's Association clinical practice guidelines for the use of these biomarkers, they more specifically indicate that these biomarkers should only be used in individuals with cognitive impairment presenting to specialized care settings. And we can use two types of blood biomarker tests. We can use a test that can be used as a triage test, which are those tests that have a diagnostic performance of 90% sensitivity and 75% or greater specificity. Or we can use blood biomarkers tests that we refer as confirmatory tests, which are those that are able to achieve both a 90% or greater sensitivity and specificity. However, it's important to note when we look at the different commercially available assays in the market that there is variability in their diagnostic test accuracy, and many of these assays are not able to meet the recommended thresholds. Furthermore, we need to understand that we should never be interpreting these blood-based biomarkers in isolation, and they are not a substitute for clinical evaluation. It is important that a clinician interpreting these test results take into consideration the pretest probability of AD pathology on these individuals based on the cognitive testing evaluation as well as additional clinical information. I want to spend a little bit of time talking a little bit more about the difference between a confirmatory test and a triage test of AD pathology. As I already mentioned, there are some differences in the diagnostic performance specification of both of these tests. A confirmatory test is one that have a 90% or greater sensitivity and specificity. In this case, a negative result rule out AD pathology with high probability, and a positive test confirms AD pathology with high probability. These tests, because of their high performance and comparable performance to CSF and amyloid PET, can serve as a substitute for both of these assays and do not need additional confirmation for AD pathology. In contrast, a triage test has a much lower specificity, only a specificity of 75% or greater, which means that these are mostly rule-out tests, meaning that a negative result rule out AD pathology with a high probability. However, every positive result needs to be confirmed by either a CSF AD biomarker test or an amyloid PET in order to really confirm the presence of AD pathology. For example, in the case of a test that only have a 75% specificity, 25% of the positive results will be false positive. When we look at how to interpret these biomarkers, we know that a single cut point for interpretation of an AD blood biomarker might not be able to achieve the test accuracy needed for a confirmatory test. For example, here I'm showing three of the most commercially available AD blood biomarkers: the plasma A-beta 4240, plasma p-tau 217, and the plasma p-tau 217 over A-beta 42. And these histograms show the distribution of the various biomarker results, both in an amyloid negative individual, showing green, and in amyloid positive individuals. As you can see, there is a large overlap between these two groups in all of these tests. However, when you look at the p-tau at A-beta 42 over 40, the overlap between the positive and the negative group, amyloid PET positive and negative groups, is much larger than when you look at the overlap between p-tau 217 and the p-tau 217 over A-beta 42 ratio. This tells us that with A-beta 4240, you will have a larger number of false positive and false negative results depending on how and where that threshold for interpretation is set. However, one proposed mechanism to get around and increase the specificity and sensitivity of this test is to use a two-cut point model, as I'm showing here with the two dashed lines. And in this case, the use of these two cut point models allows you to separate, better separate the true positive, true negative, and avoid that overlap region that is shown in the figure for all three assays. So let's look at this two cut point model in more detail. In the two cut point model, what we do is that we choose cut points that optimize both the test sensitivity and the test specificity. And these are usually done at thresholds of 90% specificity at the upper cut point and 90% sensitivity at the lower cut point. This then leaves us that a positive result will have a very high probability of amyloid pathology. A negative result will rule out amyloid pathology with a very high probability. And then you will have a group of patients that will have an intermediate result. And these are usually between 15 to 20% of the results that will follow into that category, and indicates that in these individuals, we cannot really assess whether amyloid pathology is present or not. And they will require additional testing for confirming the presence of amyloid pathology.
However, using this two-cut point threshold, we not only optimize the specificity and sensitivity of the test, and now we have a combination of a combination of a confirmation and a triaging test for individuals presenting with cognitive symptoms, but we are also able to reduce the number of individuals that will require a CSF or a PET imaging by about 80%, depending on how we set those thresholds and how many of the individuals fit into that intermediate range. At Mayo Clinic, we have implemented the plasma p-tau217 assay based on the Lumipulse immunoassay and decided to go with a two-cut point model to again optimize the diagnostic accuracy of this test. We selected the two cut points to achieve a sensitivity of 92% and a specificity of 96% to improve or decrease the number of false positive results that we might see with this assay. We have validated the clinical performance of this assay in 3 different cohorts, a cohort from the Mayo Clinic Study of Aging and the Alzheimer's Disease Research Center from Mayo Clinic in Rochester, Minnesota. We have looked at the performance of the test in an outpatient memory clinic from Mayo Clinic in Florida and have an ongoing study looking at the real-world performance of this assay within the Mayo Clinic Rochester clinical practice, where individuals that are presenting for evaluation for their cognitive symptoms are being evaluated with the plasma p-tau217 assay in addition to evaluation with either CSF biomarkers or amyloid PET. As you can see, in all 3 scenarios, we're able to reach a greater than 90% accuracy as recommended by the clinical practice guidelines, and also have a positive predictive value of greater than 94%, and a negative predictive value ranging between 84 to 94%, depending on the population study. In all 3 cases, we observe the percentage of intermediate results to be 20% or lower as recommended by the clinical practice guidelines. We have observed a very robust assay performance of the plasma p-tau217 over time. Here I'm just showing one of the quality assurance measures that we use to monitor the longitudinal performance of the assay. Here is 13 months of clinical testing across 5 different reagent lots of the p-tau217 assay. And one of the ways we look at the quality of the test and the performance of the test over time is looking at the baseline or the thresholds that we have selected and how the frequency of results fall into the different categories, the negative, intermediate, and positive results. With the benchmark being the thresholds that we established at the time of the initial validation. So we expected that about 33% of the results will be classified as negative, about 20% of the results will be classified as intermediate, and 47% of results will be classified as positive. And you can see that over time, we're able to maintain very close performance to those pre-established frequency of results in the different categories. Now, one of the factors that we need to consider when interpreting the p-tau217 values or any blood biomarker assay is the effect of comorbidities, how other chronic conditions may affect the interpretation of the results. For plasma p-tau217, there has been an extensive study done using the Mayo Clinic Study of Aging population-based cohort to evaluate at a population level what type of comorbidities might affect interpretation of plasma p-tau217. In this publication, it was highlighted that individuals with chronic kidney disease, a history of a myocardial infarction, or a clinical stroke might have elevated p-tau217 concentrations, independent of the presence of AD pathology. whereas individuals with a high BMI, in this case a BMI greater than 30, may have lower concentrations of p-tau 217. This effect of BMI as well as chronic kidney disease has also been demonstrated not only for p-tau 217 but for other blood biomarkers such as neurofilament light chain, p-tau 181, A beta 42, and A beta 40, as well as GFAP. So it's a generalized problem, a potential problem of the effect of CKD on blood-based biomarkers, and not only a problem for p-tau 217. We have further tried to characterize the effect of chronic kidney disease on plasma p-tau 217 concentrations, and here it is showing the relationship between EGFR and plasma p-tau 217 using the ELF-path immunoassay. And what we see is that both in amyloid positive and amyloid negative individuals, as the EGFR values decrease, which are reflective of a lower renal clearance, the levels of p-tau 217 increase. And we try to quantify some of the effect or the percent of increase by looking at the relationship between these two biomarkers mathematically. And as you can see in the table, as the EGFR decreases, meaning as the renal function decreases, the amount of p-tau 217 increases. And we feel that in individuals with an EGFR of 45 or lower, meaning a CKD staging of 3B or greater, the effect of decreased renal clearance will result or may result in elevations of p-tau 217. Now, the question is how this really translates into the interpretation of the results when we have pre-established clinical interpretation cut points. And a very nice study looking at a number of comorbidities have actually reported that in the context of chronic kidney disease, the plasma p-tau 217 accuracy is not really affected, and neither is affected in individuals that have diabetes. These are the two comorbidities that were looked at this study. And what you might see is that by using that two cut point model that I described earlier, that some of the individuals with chronic kidney disease will move into an intermediate range of result, and that in that sense, the results are not really being, or the individuals are not being misclassified as positive for p-tau 217, but they are being placed into this region that needs additional follow-up or confirmation to assess the presence of amyloid pathology. But the overall accuracy in terms of sensitivity, specificity, negative predictive value, or positive predictive value is not affected in the presence of chronic kidney disease. Now, as we look ahead, there is many more applications for blood biomarkers and many exciting applications that we hope to implement in the near future. When we look at the clinical need, we really need biomarkers for the detection of copathologies. We know that MCI or dementia is a clinical spectrum. The most common cause is Alzheimer's disease, but we do have other type of diseases or type of dementia. We have vascular dementia, we have alpha-synuclein type of dementia, and we have TDP-43 dependent changes that can also lead to dementia. So we really need biomarkers for all of these other type of dementia, so we can have a stronger biomarker panel for that differential diagnosis of dementia presentations. As established in the framework of AD staging, we need additional biomarkers that can be used for staging of the disease. Beyond the detection of amyloid pathology, we have biomarkers that has been proposed, such as MTBR tau 243, we have p-tau 205. However, none of these biomarkers have reached the level of a solid evidence and readiness for clinical implementation. We need biomarkers for prediction of treatment side effects in the context of anti-amyloid therapies. For example, it will be great to have a biomarker that is able to detect amyloid-related imaging abnormalities or ARIA. And also in the context of anti-amyloid therapy, it will be ideal to have a non-invasive biomarker for monitoring response to therapy. Again, these are future applications. We don't have any solid biomarkers that we can offer clinically yet at this point to address some of these clinical needs. However, one exciting aspect is the potential of using p-tau 217 as a biomarker to monitor response to anti-amyloid therapy. And this is an example from a patient that had undergone 1 year of lecanemab treatment, so one of those anti-amyloid therapies. And we were looking at the changes in both the amyloid PET imaging, as well as the changes in plasma p-tau 217 concentrations, and how those correlate with, how do they correlate with each other and to the response to therapy. So if you look on the first panel, this is an amyloid PET prior to treatment. So this individual had an amyloid PET with a centiloid of 54, and the orange regions show the amyloid plaque deposits on the brain of this individual. After 12 months of treatment with lecanemab, you see that this individual have become amyloid PET negative, and all the plaque that was in the brain has cleared. When we look at the trending in plasma p-tau 217 concentrations, we also see that the p-tau 217 concentrations decrease over time in this individual. This individual, after 12 months of treatment, has been shown to be stable both in the cognitive and functional status. We have the trending down of plasma p-tau 217 over time with therapy, suggesting that it might reflect some of the changes that we're seeing in the amyloid PET imaging, which brings the question as to whether p-tau 217 can potentially be a non-invasive biomarker for treatment monitoring of these individuals. Again, we need more evidence and more data to support this use, but it is a very promising piece of data. So to summarize, the key takeaways from these presentations is that blood biomarkers are transforming the Alzheimer's disease diagnosis in individuals with symptoms of cognitive decline. We now have clinically available plasma p-tau 217 assays that have a high diagnostic accuracy and has proven clinical utility. We have a greater understanding on the effect of comorbidities. We know that, for example, chronic kidney disease might affect the concentrations of these biomarkers in blood, but at least in the context of p-tau 217, it might not have a significant effect on the overall test accuracy. We are exploring the role of biomarkers, specifically p-tau 217, to monitor treatment in response to anti-amyloid therapies, but there is still an urgent need for additional blood biomarkers for other dementias and other intended use within the Alzheimer's disease spectrum. And with that, I thank you for your attention.